One of the great studies that came out in the past couple years was showing that how effective and beneficial spinal surgery is on improving the quality of lives. And we've all known that hip replacements and knee replacements really improve the quality of people's lives. Well, this study actually showed that spine surgery, modern spine surgery, and I think a lot of it's because of disc replacements, but all the minimally invasive techniques we do, that spine surgery is even more successful than hip and knee surgery in improving the quality of lives. And I think it's these concepts of motion preservation, decreasing stress on the adjacent levels, and then being able to focus exactly with very extreme surgical precision on the problem and solving it with a device that works much like the normal anatomy, that we can take out a degenerated, broken part and put in a brand new part and have it work as good as the other one and get people back to their lives. And so that to me is so important, and why we're celebrating and discussing cervical disc replacements tonight.
And it used to be said that fusion was the gold standard, but that is very quickly being challenged by artificial disc. And I would say, of course, the four of us here would believe that disc replacement is a gold standard, but, unless you have certain severe cervical conditions, the artificial disc is really our go-to operation. And I think all of us believe that we find reasons not to do the artificial disc. In other words, if the patient has a problem, we say, okay, well, you passed all the tests, so you're a great candidate for artificial disc, not that, oh, you're a fusion patient, maybe you're a candidate for disc.
Correct. Yeah, but I think it's important to understand that fusions aren't bad.
No, they're not bad at all.
Replacements are just better.
Yeah, and just that, as you alluded to, Tom, that, the body likes motion. That's the way the good Lord made us, is to have motion, not to fuse our body parts, and just like hips and knees.
And again, I think, Tom, you asked me the question, how do I make the decision whether someone should get a fusion or a disc replacement? There are a few, I think, fairly, at least in my practice, uncommon, because when I look at the proportion of the disc replacements that I do versus fusion, currently my practice over 95% disc replacement in the cervical spine and less than 5% fusion. But the few patients who actually end up having a fusion do have some sort of a pathology that the artificial disc will not address. One that would be if that patient has what we call clinical instability. So they are so mobile, they have so much motion at that segment that if you were to put an artificial disc in there, that continued kind of pathologic motion or abnormal motion would continue and would be to the detriment of the patient's overall function. So a patient like that, whether that's as a result of some sort of excessive degeneration and wear and tear, or as a result of some sort of trauma, is still better treated with fusion. A patient who may have excessive arthritis along those two legs on the back of the spine that you talked about. So if they have really severe facet arthritis, that makes their neck pain to the point where by replacing the disc, we will still not address the majority of their neck pain. That may be a patient that may be better served with fusion. A patient that may have really abnormal kind of surface to the disc end plates, or kind of the underlying surface of the bone, that precludes that patient from an artificial disc. That may be someone that we may still end up doing the fusion. So I think fusions will still continue to have a role in our practice. But fortunately for some of us, especially in this forum today, who have used the artificial disc technology and have expanded our abilities and our technique, will use artificial disc as our primary treatment option, and fusion only as kind of as our backup.